effect as far as the macrovascular pathogenic mechanism prevention, but unfortunately there is volume overload, so edema and heart failure could be evident. And DPP-4, of course, except for one DPP-4, all others have cleared that it has got a neutral effect, but still nothing to add to the benefit of the cardiovascular prevention. And GLP-1 is okay, it has got some benefits, but there may be a slight increase in the heart rate, particularly in the liraglutide arm. Alpha glucosidase inhibitor, of course, it's reasonably safe as absorption is much less, but still there are problems related to the inflammation and prothrombotic markers, and it cannot be used in a patient who has got a renal failure of creatinine more than 3. Next slide, 1.3. Now, where are the OADs placed as per the guidelines? Next slide. This is again a very familiar slide to tell you that if a person is being diagnosed as diabetes, he has to be prescribed metformin and lifestyle modification, which includes diet, exercise, and relief of stress. In case he is not able to tolerate metformin, he could directly be taken into the second group of drugs, or if he is not under control with metformin and lifestyle modification, he could be taken out as a second add-on, or the first add-on to make a dual therapy with metformin and one more drug. When you consider the second add-on drug, this is decided by the comorbid conditions. So if there is going to be an increased CVD risk or increased ASCVD score, the ideal drug would be a GLP-1 receptor agonist. And if it is going to be a heart failure or CKD, it is a SGLT2 inhibitors as a first line, and maybe later on another third drug could be added from each of these categories. In case the person needs a treatment without hypoglycemia, the second add-on could be anything from a DPP-4, inhibitor, GLP-1 receptor agonist, and SGLT2 or thiazolidinedione, depending upon the other prevailing complications like possibility of failure or possibility of nausea, vomiting, inadequate tolerance of GLP-1. DPP-4 or an SGLT2 would be the commonest third add-on or the second add-on, depending upon the situation. When you are really interested in reducing the weight of a person, again it comes to GLP-1 and it boils down to SGLT2 inhibitor, which is an orally acting drug with a lot of benefit. The last factor, if it is going to be the cost, maybe sulfonylurea and thiazolidinedione would be the best option in this particular regard. So today we are going to focus on the most important drug which falls under all categories. Today, DAPA also, as well as some of the DPP-4 inhibitors have also become cheaper. So these are the two drugs which could be used in any of these categories. Next slide. So this is already, as I've told you, you can move on to the next slide. So when you have a patient, this is ACC guidelines 2018, and maybe this is again concentrating on the same protocol, but probably SGLT2 and in DPP inhibitor are to be thought of, not to be thought of in situations where there's pregnancy, or currently breastfeeding, or ESRD. Next slide. Now we have the three important options. That is, for all diabetes, wherein kidney as a therapeutic target was completely ignored. We never knew that. And now we have gotten avenue. And the next important point is that when you are trying to give a OAD for diabetes, it would be better if you could give a little more bonus for this particular patient as far as safety and probably an increased survival benefit, as well as decrease in the cardiovascular mortality, MACE, or what you have as a heart failure. This heart failure was completely unknown. When I was doing my MD general medicine long ago, my professor would just choke my neck if I say cardiac failure in the absence of an acute or an old myocardial infarction. At that time, even ischemic heart disease could never produce high heart failure. This was the concept. Later on, we knew that even without a myocardial infarction, patient can develop heart failure, and even with ischemic heart disease, a dyskinetic segment can produce heart failure. And today we know that even without an ischemic heart disease at all, diabetic involvement in as far as the cardiac muscle fibers produces the diastolic dysfunction, the heart failure with preserved ejection fraction, and heart failure with reduced ejection fraction. So these are the two important categories which have come to know recently. Next slide. We are not going to talk about the glycemic control or the glycemic efficacy about SGLT2 inhibitors today. But remember, this is another new venture that we found that this was useful in disposing of glucose in a larger extent, and that too in an insulin independent mechanism of action, and see to it that the blood sugar is under control. So this came to being after understanding the filtered glucose load and the glucose excretion per day, and how excess reabsorption happens in a diabetic patient due to increase in the SGLT2 receptors in the proximal convoluted tubules of the renal unit. And this produces an added load of glucose to the bloodstream and increases diabetes. So it has been found as a pathogenic mechanism as well as a therapeutic avenue as far as diabetes is concerned. Next slide. So this is because you try to reduce the threshold, so the blood glucose is excreted without being reabsorbed in the urine, thereby reducing the blood glucose which is prevailing, and that too not involved with insulin secretory capacity of the individual. Next slide. So this is just to show you that the renal reabsorption at the proximal convoluted tubule does two important things. One is the glucose block at this point of time is important. Another important thing is the amount of sodium which is presented to the macula densa is again an important factor to control the benefit of the afferent and efferent arteriolar caliber, which also gives way to the management in a better way. Next slide. So this is what ultimately we get, that is, there is a reduction in the blood glucose, there is a reduction in body weight, there is a reduction in blood pressure, there is a reduction in uric acid, and also the glomerular hyperfiltration is reduced. So in all these ways, we knew only about the plasma glucose. All of the things came to us after the recent developments on the SGLT2 inhibitor. Normally, in any research and clinical practice, it is always from the bench to the bedside. So you discover a drug and then apply it. You know everything about the drug and then you apply it in a bedside or a patient clinical setting. But this is something very unique for this molecule, that it is from bed to the bench, and from bedside to the bench. We realized that it had a very good effect on glucose reduction. We were happy, we started using it. Then after knowing that it has got so many other benefits, we never knew how these benefits are achieved. And then we started to know about it in days to come. And today we know that we have got a lot of mechanisms in this particular pathogenic mechanism being blocked, and the pathogenic mechanism, and in case if it is going to be the pathogenic mechanism for the prevention of cardiovascular entity, renal effect, all these things are known today only. Next slide, please. So this is a very busy slide wherein we are going to trace how the particular molecule is useful for the cardioprotection and how it is going to be effective in the nephrological segment. So starting from glucosuria or glycosuria on one end and natriuresis. So it is a sodium glucose reabsorption is going to be interfered. And when you have a way out of glucose reduction as well as sodium reduction, you have the two major class of benefits. When blood sugar is reduced, there is a negative caloric balance, total body mass is reduced, the epicardial fat is reduced, and there is an increase in the cardiac contractility, which gives you a benefit of direct cardiac protection as well as a reduction in inflammation and fibrosis, which makes the particular heart going for a diastolic dysfunction or a rigid, small, contracted heart. So that is how this is going to be useful for a specific diabetic complication of heart. The next thing is, as you know, hemoglobin A1C comes down with less of inflammation, less of glucotoxicity, beta cells recover, and that also helps in the metabolism of the heart, thereby protecting it, and also reducing the atherosclerosis. The third thing is about uricosuriya, that is uric acid, which is again a very important factor for macrovascular complication, is also reduced by reducing the uric acid level in the bloodstream. These are the ways and means of getting cardiac protection. Coming to the kidney protection, when you have a sodium reabsorption which is going to be interfered with, there is excess sodium excretion by the kidney. Thereby, you have a reduction in the blood pressure, reduction in the arterial stiffness, and you have a kidney protection. The second thing is again the tubuloglomerular feedback of afferent arteriolar constriction, secondary to the macula densa effect in the in the later half of the proximal distal convoluted tubule and renal tubules, vasa rectae. There you have the benefit of controlling the input or reducing the input into the glomeruli. Thereby you have the afferent arteriole getting a little smaller and the efferent arteriole in the normal or slightly dilated one. This gives you an important factor of reduction in the perfusion pressure, which protects the kidney. Moreover, there is a reduction in the plasma volume. That too, the interstitial fluid, interstitial space, fluid volume is something which is reduced or depleted. So this helps the myocardium in causing reduction of failure, heart failure. And also, when plasma volume is reduced, the myocardial stretch is reduced, ventricular arrhythmias are less, and that also helps in the protection. Lastly, there is activation of ACE2 as well as the more sympathetic activity is also suppressed. That is, it is not activated. Thereby, you have little more cardiac protection. Next slide. So ultimately, this drug helps in not only bringing a reduction in blood glucose level, but also cardiac as well as cardiac, renal. And today we have also got evidences to say that is also helpful in reducing the SGLT2, NASH in days to come. Next slide. This is a story of evolution of this drug. Started from the bark of the apple tree. Today we have got many of the gliflozins, the Cana, DAPA, EMPA, etugliflozin, as well as today we have got DAPA back again with a lot of price reduction so that our common patient would be able to afford this particular entity. Next slide. So coming to the various clinical trials, lots of trials as far as cardiac glycemic control is concerned, the CVD is concerned, as well as DAPA is in CKD concerned. So as I told you, initially we never thought about it. We wanted that this drug should be safe. Light area. So when we tried to do that study, we came to know that there is cardiovascular benefit, not only neutrality, but beyond that you have an effect. In the sub-study, it was found that it was useful for renal parameters also. So then the trials which were dedicated for these outcomes have been tried, and then we have got into a lot of evidences to say, like Declare-TIMI, Determine, DAPA-HF, CVD Real Nordic, DAPA CKD, Delight. So all these trials have given us an idea that it is not only a diabetes-oriented drug, but also the cardiac as well as renal territories. It is a very important drug to be used to reduce these complications. Next slide. So this is what I was just been, next slide. I've been talking to you about beyond glycemic control. You have a lot of benefit. So here with metformin, gliptin, with sulfonylurea, thiazolidinedione, and as add-on to an insulin. So in all these studies, you can see the DAPA arm showed a lot of benefit of reduction of hemoglobin A1C at even week 24. Next slide. So it's a molecule which could go with any other anti-diabetic drug. That is also very important because It's not going to be the only drug for diabetes. Definitely, you may need an insulinotropic drug. You may need an insulin itself, or you may need even other insulin sensitizers. So in any combination for that matter, DAPA has always been superior compared to other drugs. So for example, the placebo is better. When you have pioglitazone and DAPA, you have the benefit. And with DAPA and glimepiride, you see the benefit. So you always combine, you get the maximum benefit. Next slide. There has always been a systolic blood pressure which is also reduced. It may not be 10 millimeters and 20 millimeters, but a mere reduction of 4 to 5 millimeters of mercury is more than enough to get you a lot of benefits. And if there's going to be an increase of 5 or 10 millimeters of mercury, then drawbacks are more. So this drug produces a reduction in the blood pressure by about 4.5 to 5.3 millimeters of blood pressure, which is also quite useful and helpful in prevention of cardiovascular disease. Next slide. Now we'll talk about the DAPA and the CVD outcomes. Next slide. So this is the original article from NEGM, DAPA and cardiovascular outcomes in type 2 diabetes. I will not go into the details of all these trials. The most important primary endpoint is safety endpoint, composite of CV death, MI, stroke, and 2 efficacy endpoints, composite of hospital admissions or hospitalizations for heart failure or CV death or MACE. Next slide. When this particular thing is done with a double-blind placebo-controlled trial, next slide. This trial was declared to me. You see the separation of the curve between the placebo and DAPA starts much earlier and has been clinically significant. There was about reduction of 27% relative risk in the overall population and 0.8% reduction in the absolute risk reduction. And the reduction in the risk of hospitalization for heart failure in pre-specified subgroups of primary and secondary prevention have also been obvious. So death from any cause, MACE, renal composite, or cardiovascular death or hospitalization heart failure, in any parameter you mean, it will always be useful. Next slide. So cardiovascular mortality and morbidity in patients, what is called as a CVD real Nordic. This is again another trial wherein the primary endpoints are similar to MACE, similar to the other one like MACE, heart failure, and all-cause mortality. Next slide. And this is a comparison between DPP-4 inhibitor as well as SGLT2. I would not compare these two drugs except for a situation wherein you would like to know whether this has a better cardiovascular outcome and renal outcome and all-cause mortality when compared to DPP-4, because this comes under different class, that comes under different class. However, considering these two, DAPA has always been significantly useful in reducing MACE, heart failure, and all-cause mortality. Next slide. Coming to diversity CVR, this is the efficacy of DAPA versus sitagliptin on cardiometabolic risk factors in Japanese patients, and it also showed that the composite endpoints, hemoglobin A1C level, avoidance of hypoglycemia, and weight loss. When you consider all these things between SITA and DAPA, DAPA scored over SITA in 2 important things, that the composite endpoints as well as the another important thing, weight reduction. So these are the 2 important things wherein it was quite significant when compared to DAPA. Next slide. DAPA and CKD outcome. So the other component of other arm of the DAPA. Next slide. What happened to the DAPA in patients with chronic CKD? This is called DAPA CKD trial, of which I was also being one of the principal investigator in this particular trial, wherein the study duration was a quite long period of 2.4 years, and the primary endpoint was composite outcome of sustained more than 50% of eGFR decline, ESKD, renal or CV death. The secondary outcomes where composite outcome of sustained more than 50% of eGFR decline, end-stage disease and renal death, CV death, or hospitalization for heart failure. Next slide. So here, among the patients with chronic renal failure, regardless of presence of or absence of diabetes, the risk of composite of a sustained decline in estimated EGFR of at least 50%. End-stage renal disease, all this significantly lower with the DAPA arm than with the placebo. You look at the graph, it separates quite early, and it shows the primary composite outcome, the renal specific composite outcome, the composite of death, cardiovascular causes, or hospitalization for heart failure, or death from any cause. All these parameters, DAPA scored over the placebo. Next slide. So this is a delayed study wherein albuminuria, probably this is one thing which we always try to do and say that the patient has got some renal involvement. So albuminuria lowering effect of dapagliflozin alone and in combination with Saxa, and effect of DAPA and Saxa on glycemic control in patients with type 2 diabetes and chronic disease. I said it was a randomized double-blind placebo-controlled trial, which also showed that DAPA with or without Saxa, given in addition to ACE or ARB, or that is an important prerequisite for renal, that is a standard of care. So that has to be there on both arms, and see whether there are any benefit of this particular molecule. It was found that when compared to the saxagliptin, 24-hour urinary albumin excretion was much better, and improvement was better when compared to the baseline. Next slide. So this is again a very busy slide to just show you that the lowering efficacy, the glucose lowering efficacy of sodium glucose cotransporter or SGLT2 of DAPA when compared to other SGLT2s. This is not actually a head-to-head trial. However, you'll have to have an idea that with these molecules like CANA, DAPA, and epagliflozin, there has been similar effects as for the class effect. But beyond that, there is a specific benefit of DAPA, and we have got the evidence to say that DAPA has scored over the other SGLT2s in various other parameters. We'll get to know about it in the later slides. Next slide. So this is again a detailed thing comparing EMPA-REG, CANVAS, DECLARE TIMI, and the VERTIS, which is an ongoing trial. As I told you, these are not head-to-head comparison, but in all these parameters, we have come to know that all these are quite useful, and particularly DAPA in the DECLARE TIMI has proved that it is beneficial at various levels, 3P MACE, renal parameter reduction, as well as atherosclerotic cardiovascular. So what more do you want? Next slide. So this is dual phase availability, which you are all familiar with. Next slide. And this is a bright study wherein DAPA does what really want any drug to do. So it improves symptoms, it improves survival, it reduces hospital admission. So that's what I said. What more do you want? And there are so many trials beyond glycemic control, and now even 80 trials are ongoing about various aspects of cardiac failure, renal damage, and as I told you regarding the NASH, or the non-alcoholic fatty liver or non-alcoholic hepatitis. Next slide. So ultimately, it is a very important drug, just like a diabetologist, I would always say, because a diabetologist is a person who should treat diabetes and also prevent complications of diabetes like cardiovascular mortality, 3P MACE, as well as a renal involvement. So that is why this class has been an ideal, or probably similar to a diabetologist, that it is able to reduce blood glucose well and good, and also has a benefit of preventing and reducing the increased cardiovascular risk or the renal risk, thereby helping or bridging the gap of diabetes treatment and the complication treatment. And hence, it has also been recommended by the reputed bodies, preferred guidelines like ADA, EAST, ACC, in the management of type 2 diabetes, whether it is with ASCVD or heart failure or CKD, or for obesity, or even for hypoglycemia or prevention of hypoglycemia, or for even today it has also been extended to the cheaper class of drug. Thereby, many of our patients who are not able to afford this particular drug is able to have this within the reach. And there are almost 350 completed trials, 80 more to go. And the declarative, DAPA CKD, delay have all proved that cardiovascular as well as renal benefits are not only due to the diabetes control, because it could be used even without diabetes itself. So gradually DAPA is being taken up by the cardiologist and nephrologist much more than the diabetologist even. So it has become a cardiac drug, it has become a renal drug apart from it being a diabetologist drug. So the future is bright, a much needed molecule, bridging the gap of heart, kidney and blood glucose. So tomorrow it may be NASH, and day after tomorrow we do not know. It could also probably help in retinopathy. So if that is also documented, then we will have a single drug which could manage diabetes and its complications like a diabetologist. Next slide. So with that, I sincerely thank all the viewers for your patient listening and also for the opportunity given to me. I'll be too happy to answer some of your queries. If one of you could collect the question and pose it to me, I will be able to answer them. Murugan, you could unmute yourself and talk.
Sir, thank you, sir. You have so very well placed perspectives of dapagliflozin, SGLT2 inhibitors, guidelines, place in therapy, the available data, DAPA HF and DAPA CKD. Sir, there was one question that we had in place. Sir, in the clinical spectrum of a heart failure patient, in the clinical journey of a heart failure patient, from ADHF, acute decompensated heart failure, managed in the ICU, brought down to the step-down ICU, later stabilized, got to the ward. So where in the journey of that patient must dapagliflozin be or can be initiated?
So the point is very clear that we have got evidence now to say that it reduces heart failure admission. So for that, even without a heart failure, it could be given. That is number one. First slot. The second slot is heart failure, which is a chronic failure. So these are the two areas which are 100% indicated. Regarding acute heart failure, I would rather leave it to the cardiologist's choice as an add-on drug to the usual anti-failure measures. So you can't afford to just give DAPA in an acute LVF patient.
Absolutely,
so
sir.
There, diuretics, oxygen, and other drugs to have an inotropic effect of the heart are all needed. And probably this could also be useful in taking out the interstitial fluid, which no other drug can do. So particularly when you give a diuretic, it will always reduce the blood volume or the intravascular volume. But once the intravascular volume is depleted, the extracellular and interstitial fluid gets rearranged, and then it has to come out to the vascular compartment and then only excreted. Whereas this particular drug has a unique mode of action that interstitial fluid is being sucked out by this particular drug. So this could be used as an add-on in acute LVF, but not the only drug for LVF.
Sir, on a similar note, in renal patients, in your patients with diabetic nephropathy, so what are the clinical challenges that are faced when your patient is on dapagliflozin? Your clinical experience, sir.
So the point is very, very simple again, that this is a drug which can be blindly given to any situation. So just barring a very low eGFR, it could be used in any situation for that matter. We had insulin as that particular drug. So insulin could be given in a normal person, I mean, a person who is just detected to be a diabetic, in early intervention of insulin to even suppress glucotoxicity, for a person who has an acute complication, a person who has failed with OHA, a person with all complications of diabetes, insulin is absolutely indicated. Probably the next drug which could be used in any of these avenues is the SGLT2 inhibitors. So here, if you diagnose a person or an obese diabetic, and if he is not able to tolerate metformin, or you can even go ahead with one step, that it need not be metformin always as a first drug. You could even start them on an SGLT2, wherein there is going to be a weight reduction, good glycemic control. You are going to safeguard from hypoglycemia and also prevent him from entering into any of these complications like heart failure, IHT, stroke, as well as renal problem. So that is another important segment wherein you can use. Now, if the patient has become a cardiac patient, you can't use a long-acting sulfonylurea. You can't use a thiazolidinedione. And if his eGFR is low, metformin may not be an ideal drug in all these situations. Of course, metformin could be a drug which can be used to as much lower eGFR as possible. Now, with this particular limitation, DPP-4 can worsen heart failure. So, if you have a patient who is going in for a heart failure, you have eliminated almost all other drugs other than insulin and this particular drug. If the person is going in for renal failure, you will have to cut down the dose of DPP-4 or change the DPP-4 to a different DPP-4, which is going to be dually excreted, like linagliptin or teneligliptin. Unless otherwise, you may not be able to give a blanket prescription. Some of our patients who do not want to do any of these investigations want us to give a drug after checking blood sugar. So I always used to say, if you ask me to give a best drug for this situation, I will give you only insulin. And after that, they will try to do for any other investigation. Because insulin, even if there's going to be a heart failure, you need not bother. Even if it's going to be ischemic heart disease, it is not a problem. Even if he has got a renal failure, it is not going to do any harm. In the same way, this is a good drug which could be used in any areas or from this end of the spectrum to the other end of the spectrum, wherein even if it's going to be a CKD, no problem. Even if it's going to be ischemic heart disease, no problem. Even if it's going to be a NASH or another, even a mild dysfunction of liver, it's okay. And then finally, glycemic control is achieved. So nowadays, probably this drug and this spectrum of drugs would be the best choice to a patient, even at the beginning. And probably in days to come, we will have evidences to say that, see, today we know after the verified trial that vildagliptin could be started straight away along with metformin from the beginning with a hemoglobin A1C of 6.5. So I would not have started this without this particular evidence. And tomorrow, if you have an evidence to say that you can start SGLT2 or a DAPA or whatever it may be from the beginning with metformin, then that really gives you little more durability, less of complication. Probably I would rather venture on that. So the future is going to be little more interesting, that we'll have more indications for this usage of this particular drug.
So we've completed the questions. So thank you very much for the amazing session and the very lucidly and very clinically placed perspectives on dapagliflozin, with perspective of guidelines, with the evidence of available data, with the clinical practice perspectives, plus the wonderful flair that you gave the entire clinical spectrum of its entire usage. Thank you very much, sir.
So thank you very much for the opportunity. Thank you. Wish you all a very happy new year. And probably this year should be a COVID-free year. Thank you. God bless you.